This is an interesting case. Patient presented like this. You would think from this picture that, okay, there's one tooth missing and we're going to do one implant and everything's going to be good. So I asked the patient, what happened to that tooth? She said, nothing. I was eating a soft sandwich and the tooth just fell out. I said, the tooth just fell out. I said, when did that happen? He said, a couple of weeks ago. And you look at from the socket, you don't see deep socket. So we said, okay, let's take CT and see what's going on. So here we did the CT, and now we realize why that tooth fell out. If you see, she has severe root resorption on these teeth, and tooth number 9 has probably a millimeter and a half only in the bone, and there is no root for it. Similarly, tooth number 7 and 10 have very short roots. Here, that's tooth number 10. Tooth number 10, I think, is being held in just by gum. There is no root of the tooth number 10 in the bone. So the treatment kind of changed from needing one implant to needing, well, and this is tooth number 7. Tooth number 7 also, you see there's hardly any root. But once we go more posterior, then it's more normal. That's tooth number 11. The root is not as long as it should be for that tooth, but it's long enough that the tooth is in patient's mouth and probably would stay long term if the occlusion and everything else is done right. And this is tooth number 11. Again, the root of the canine is not as long as you expect it to be, but it's long enough for now. So bottom line, one tooth fell out, the other tooth is being held by the gum, and the other teeth is like millimeter here in the bone, and here about a millimeter and a half, 2 millimeter in the bone. So the treatment becomes obvious now. The other 3 anterior teeth are about to fall out too, so we need to remove those two so that accidents like this don't happen. Now the treatment comes to, once we have the 4 upper anterior teeth missing, we can do 2 implants on position of numbers 7 and 10 and have a bridge, or we can have 4 implants. Will 2 implants suffice? Yes, they will. Now there's a little patient input here that the patient says she has a lot of events coming up next few months, including, I don't know, a daughter's wedding and a whole bunch of things that she cannot go without teeth, and she cannot go with something that is moving or temporary in her mouth. So if we place 2 implants in number 7 and 10, most likely the patient has to have a flipper as a temporary. Or we need to do a bonded bridge from 6 through 11 in order to give her a temporary. Given the fact that number 6 and 11 themselves are not that strong, I didn't want to make them abutment to bridges there, to a bridge there. And the flipper patient said, no, I can't talk, I can't, be confident enough, and I want something temporary, fixed, without anything on the roof of my mouth or anything moving. So that kind of moved the treatment from 2 implants to 4 implants, because if I place 4 implants in that area, I can do an immediate load on those 4 implants as a temporary, and if the patient is careful, that should be okay. So we plan for removing the 3 teeth, immediate placement of 4 implants, and immediate loading with a temporary. So we scanned the patient at this stage, and we had the lab make polycarbonate temporaries from 7 through 10. And let's go look at the surgery, and I'll show you the post-op x-rays afterwards. Normal local anesthesia is done. Of course, this patient, I think we also did IV sedation, but pain control is by IV sedation. The incision, intracellular, all the way to the crest of the bone. I try to avoid vertical incisions as much as possible so that not to compromise the circulation. From the missing tooth, the incision is to the midline. Then we elevate a mucoperiosteal flap. Now, these are the easiest extractions you can have. Very little root. Number 9 and number 10. Now, with the high speed and surgical carbide burr, number 3 or number 4, I clean the granulation tissue. Then I do the initial pilot drills 2 at a time and make sure they are parallel and they're not encroaching on the adjacent teeth. After the pilot drills, we go with the yellow drill. Now, at all times, I make sure that my drilling is parallel to the palatal bone, because on the buccal, if it's necessary, we can always add bone. I'll place the implants, Implanova. These are 3.5 by 12s, I think. No, 4.5 by 12s. I take them down by hand, and then with the torque wrench, I take them to the depth. Now remember, we want to do immediate loading on these. So we are trying the temporary, which is pre-made. Now, see, I did not reflect the flap completely so that to preserve the gum line. There are plenty of advantages with that. This is a picture of the area after 1 week. As you can see, patient has followed the instructions very well. And the white material, that's materia alba. That's because patient has been careful. You can see how nicely the gum is adapted to the temporaries. Of course, those temporaries I relined on those abutments. And this is the post-op x-rays of the 4 implants. Now, the point of this case is to show that if you want to do immediate placement and immediate loading, you need good stable implants. And in the anterior area, with these 4 implants, I think the patient is set for the rest of her life as far as these teeth are concerned. And these are not going to go anywhere, and she's not going to have any problem. And so far with the temporary, she hasn't had any problem, and she's a happy camper.